So we're going to move now down the line to Jane Zapka. Jane is has been working with us at the National Cancer Institute for a while. She has a long history in working in community and cancer control activities. She's a professor at the Medical University of South Carolina, and she is a longtime friend, a longtime collaborator, and I'm honored to have her here with us and working with us today. And she wants me to get her PowerPoint up.
Good morning. I wanted to first acknowledge my co-authors on the manuscript that will be coming out in the supplement, Drs. Taplin, Gantz, Grunfeld, and Sturba. As Dr. Taplin has illustrated, the cancer care continuum represents several types of care, each with multiple technical steps and interfaces requiring communication. In our manuscript, we use two case scenarios to illustrate the variability, diversity, and interaction of factors from multi-levels that impact quality of care. These scenarios included a review of the literature about factors which could affect various processes and interfaces of care. It was hoped that the manuscript would present cases which put a human face on some of the concepts that we're talking about. The next step was that we then use hypothetical examples, and we illustrate intervention strategies at different levels which are hypothesized to produce complementary, synergistic effects to improve outcomes. Case 1, screening in the elderly. It was the screening on the continuum of care. Ms. Smith, 66 years old, a widow, worked for 40 years in an assembly line. She is using her free time now to pursue an active social life and visiting her daughters. She did not often see physicians because of limited insurance, and she is generally healthy. She has not been screened for colorectal cancer or breast cancer and has not been screened for cervical cancer in 25 years. With respect to the levels of potential intervention, there are numerous options. Our paper has a table which illustrates examples from the literature at each of the levels for each of the cases, and that table has been included in your handouts there. We did a review of the literature as we looked at these issues to illustrate what has been done in a variety of studies. So very briefly here, state health policy, maybe one way to look at special program for education, for access. Organizations, are there community outreach projects that could help with education? Can the organization promote an outreach reminder system so that if a patient comes in with a different issue, that screening can be brought up and highlighted as well? In terms of provider team interventions, are there certain incentives which might make a difference? And clearly at the individual level, health and functional status require patient-centered approaches, including those which impact knowledge and attitudes. Ms. Smith's screening and her lifestyle may require such an integrated approach. Our second case illustrated another type of care along the continuum, cancer treatment, but highlighted that interface and step from treatment to transition to survivorship. Zoe is 42 years old, diagnosed with breast cancer on first screening mammogram 18 months ago, stage 2 with axillary node involvement, surgery, radiation, and chemo. Numerous symptoms persist: fatigue, weight gain, pervasive anxiety. She wants to return to work, but is having difficulty because of the symptoms. She senses her family feels she should get on with her life. She has not seen her primary care physician since diagnosis. Again, there are several potential levels for intervention. State policy, for instance, has a role in insurance mandates and what types of care may be mandated. Healthcare organizations can look at the quality of their electronic medical record and how might that be used to improve communication between the patient, but also communication between providers. And does a community health, a cancer center, for instance, institute a care plan standard of behavior that they expect their providers and team to carry out? In other words, is the provider team functioning then, and do they use a good electronic medical record system? In terms of transitions and treatment and survivorship, family understanding and communication is very important. What intervention strategies might work there to improve knowledge, attitudes, and their own skills? Moving along to the hypothesized examples for strategies, at the end of the oval, broadly defined, is the need to improve patient-centered and appropriate timely screening. The red rectangles illustrate potential targets of the intervention and intervention strategies. So for instance, in the upper box aimed at the provider team, could a guidance education, a guideline education and detailing strategy improve behavior to reach the long-term outcome? Additionally, can patient education, such as mass media, lay educators, be put in place? Here you're targeting the community level knowledge outside of the practice system. These two interventions could improve provider team knowledge, skill, and motivation, and also patient knowledge, beliefs, and motivation, so that they would then have a productive provider-team-patient interaction. The upper right-hand box, however, highlights that an organizational strategy instituting in their electronic system a health maintenance template to cue the physician to bring up prevention issues could actually escalate the impact of the first two strategies. And thus, you have three strategies which are designed to improve the mediator measures which get you to your outcome. In terms of the survivorship example, here's a hypothetical case of a community cancer center trying to improve survivorship. The long-term oval, again, being coordinated survivorship care, which ultimately improves health outcome as well as quality of life. Backing up to the left part of the diagram, an intervention targeted at policy. For instance, accreditation agencies are recommending summaries and survivorship plans. At the organizational level, leadership might decide to have designated staff assignments as nurse and physician champions, as well as appointing a patient navigator and educator, as well as the usual provider individual orientation. This would promote a hospital team readiness. Interestingly, and this is happening in some of the NCCCP projects, where community cancer centers institute a community-focused effort to involve primary care partnerships. This then coupled with the patient education and post-treatment session, as well as follow-up telephone call access, will promote knowledgeable, empowered, and self-efficacious patients. Again, these are two hypothetical example based on some of the evidence that we saw in single targeted subjects. So we hope you will consider the process of identifying the potential multi-level determinants of care quality. Do we have models to guide the prioritization of strategies at various levels to produce specified outcomes in need of improvement? What problems within each type of care or interface of care should be research priorities, given the data we have in this country. Thank you.